You're listening to the What's Happening podcast with Gary Watts.
Good morning. I'm here with Dr. Patrick McNamara, who's in charge of the neonatal unit at the University of Iowa and takes care of all the babies, premature babies, right? Good morning, doctor.
Good morning, Gary.
How are you?
I'm not so bad, thanks.
The weather's not too bad today. It's not like it was last week.
Better than last week, yeah.
So tell us a little bit about yourself. I know you're from Ireland. You went to med school in Belfast, right?
That's right.
But if you could just tell us a little bit about your family, your kids, and how you made the track to University of Iowa.
How much time do we have?
Whatever you want.
That's a long story. So, so I grew up in the west of Ireland, in a small town called Ballina. Actually, it's got some U.S. ties. Our current president, Joe Biden's ancestors, are from Ballina. Yeah, and he was there back last maybe October, November. It was a big day for the town. So
I think I did see that.
Yeah.
Is Biden Irish?
I don't know. That's an Irish name. I think it's on his mother's side.
Oh, okay.
From my memory, that there's people there. So yeah.
Okay.
So there are people in the town that they've been to the White House and stuff
Oh,
like
really?
that. So yeah. So it's a big deal. Although quite a lot of U.S. presidents seem to have some connection with Ireland.
Did he drink a pint, or do you know?
I'm sure he did. not on the stage.
Okay.
Not on the stage. So. But anyway, so I grew up in the west of Ireland. There was no medical people in my family. My dad's a teacher. Unfortunately, he passed away last February. My mother kind of was at home with us and then became a Montessori school teacher when we all vacated the house. So I'm the only medical person in the family. I went to Belfast to medical school there. That's a long history why Belfast, but it was a good decision at the time. And I did most of my training between the north of Ireland and the UK, and then I went to Canada in 2001. Everywhere I went, I had a child. So my first was born in the north of Ireland, then we moved to the UK, and my second was born, and then one in Canada. I actually forgot my first was born in the Republic of Ireland. So number 4 was then born in Canada. So we stayed in Canada for 17 years.
Residency or what were you?
No, I was pretty much done my training. Most of my training was done in the UK.
In the UK.
And the reason I went to Canada was I have this very specific interest or focus in the neonatal heart, a field called neonatal hemodynamics. And I went for 2 years to do a specialty fellowship in echocardiography. And echocardiography is the study of ultrasound of the heart. And this is something that really the field of neonatology had not embraced. We can talk about that kind of in a little bit later. But I built that field there in Toronto prior to being recruited in 2018 to be the division director here at the University of Iowa. As I said, I have 4 children. My oldest is actually in med school in Ireland. He will graduate in this June.
Oh, great.
He may come back here. He's currently doing the match, so looking for trying to find a home somewhere.
What department?
At this point, it's not clear. He has applied for pediatrics, mostly. So, as to what part of pediatrics, I have no idea. Yeah. My third's a college soccer player. He actually was on trial in Ireland there last summer, and actually was offered a professional contract to play soccer. So,
really?
I went with him, and kind of that was a lot of fun. So he's kind of coming up to the end of his time he's at Western Illinois University. So try to figure out then what comes next. Is he going to go back, and because they kept the contract open, for him. My youngest is just started as a freshman here in Iowa during neuroscience. And my second is a bit of a journeyman. He's a little lost at the moment, not quite sure what he's going to do, but he manages the dogs at home. We got 3 dogs, so he's the dog orchestra conductor.
You're talking about soccer. It gets pretty wild in Ireland and the UK, doesn't it? Soccer.
Oh yeah,
the matches between.
Oh yeah, it's
Manchester. I watched Ted Lasso, so that's why I got to bring that up.
Yeah. So, we don't mention Manchester. I'm a Liverpool fan. No,
don't do that.
No. Yeah, I'm a passionate Liverpool fan. Always have been since I was young.
So you got to Iowa City, and so are you like the head of the neonatal department, or?
Yeah. So the NICU is the biggest division within pediatrics. Okay, there are many divisions. So our focus is exclusively the intensive care of sick babies.
Okay.
And it's a very niche field. and obviously we serve the smallest patients
Right.
in the state, and that line in the sand just gets smaller and smaller as time goes on. We actually have a baby in the unit at the moment that was born at 240 grams and is about 3 months old now and is doing tremendously well.
What's the youngest, like 24 weeks, 23 weeks?
No, we have in the past 18 months, we've had 4 survivors at 21 weeks gestation. 4.
That's
And they are doing remarkably well.
That's
you know, and
amazing.
It's, yeah.
You talked about the heart. I read something, I don't know if it's true, you would know, that you can hear a heartbeat at 6 weeks, when they're 6 weeks old, the fetus.
Oh yeah, it's pretty early on that you could hear. Yeah.
That's amazing. So I think a lot of people, when we had 3 children, and we all decided that we had them all at U of I just because of the NICU. Well, great pediatricians and obstetricians, but we just thought, something happens, why not have the NICU right next door here? And we're so fortunate to have that here. But it's world renowned now, isn't it? The NICU.
It is.
It's just amazing. I've heard all kinds of things about Iowa.
Yeah, it's. I would say, it is the jewel in the crown of the state. Not just the hospital, because, you go across the world, and I've been to pretty much every continent giving talks, and people know about Iowa. Not because of the Field of Dreams, but because of the NICU.
Yeah.
No, it's and it's got a global reputation for 2 things: the care of the tiny babies, and now since I've come here in 2018, this field of neonatal hemodynamics, which is a better way of more precise care of children's hearts when they're born very, very premature. And we're inundated with visitors from pretty much every continent to Iowa coming to learn from us so they can take it back to their country and try and enhance the care to optimize the care of their patients. I think that's our mission. Our mission is not just to take care of the smallest, sickest babies in Iowa and provide the best outcomes, but to do that for babies everywhere across the world. And that involves teaching and educating and so forth. So it's a privilege, to lead the program. But as a state, this is a big deal.
And just think how many people you train. Look how much knowledge they have when they come in and study at Iowa and see the babies and what you guys do. That's just, they go out and they take care of probably hundreds, if not thousands, of babies.
And then they teach people.
Yeah.
And it's a ripple effect, and then it spreads. And kind of one of the reasons I came to the United States in 2018 is I felt my journey was done in Canada, because this field of hemodynamics, and just to kind of make sure that people will understand what that is it's the use of echocardiography or ultrasound to determine why does the baby have instability of their heart rate or their blood pressure. Okay, and the analogy would be the mechanic. I love to tell this story. When you go, your car has a problem, you expect not the mechanic to guess what the problem is by not lifting the hood. You expect them to lift the hood, figure out what's wrong, fix the problem. Okay. Pretty much all across the world, prior to the evolution of this field, people were providing care, but an educated guess. The blood pressure is low, so let's make it high. Let's just do something that may work. And sometimes they get it right, but oftentimes they'll get it wrong. And, when I started this off in Canada back in 2003, there really was nothing, and it was pretty controversial to do this because, echocardiography is a field traditionally in pediatrics that is performed by pediatric cardiologists. So this was their world. But as pediatric cardiology evolved as a specialty, their focus was the anatomy of the heart, not necessarily its function, its physiology and flow, etc. So we in Toronto did a lot of research demonstrating the benefit of this and started to train people. So by 2018, when I left Canada, we had established this as a standard of care in all of the large NICUs in Canada. Now, Canada's a huge country, as you know, but there are only 15 NICUs. Really? So it didn't take 15 large NICUs where this would be of benefit. So it didn't take a huge amount of time. In the US, hundreds, maybe 500 plus NICUs. But the field didn't exist here. So when the opportunity arose to come to Iowa, which was a world-leading program already, the possibility to add this on to have a second flagship was just unbelievable. So this is the place that we pivot off now in the United States, and we have trained people that go off to different organizations. Obviously, the Iowa program is the biggest program, but we now have a program in Oklahoma. We've got one in Orlando, one in New York. So it's mushrooming out now in the United States. And the more we train, they will train people, and before you know it, it'll be a national endeavor.
So what exactly what is that again? Tell us about that. Tell us about the heart, what you do with what did you call that?
Echocardiography.
Yeah,
or ultrasound. It's
ultrasound. Okay.
It's ultrasound of the heart. So like there's the premature heart, as you can imagine, the heart is a muscle.
Right.
And like any muscle, it has a certain level of ability. So if we go to the gym, you can't bench press all night long. If you can, you're a pretty impressive person. But the heart is a muscle, and the preterm heart is very immature, meaning that in certain stressful situations, it may fatigue, it may fail, and that's not always very obvious by just looking at the baby from the outside. So we use ultrasound to evaluate these tiny hearts to give us pictures, obviously live pictures of the heart contracting, the heart relaxing. We measure the blood flow going to the lung. Is there enough going to the rest of the body? And if there are disturbances, what exactly is wrong? So it's a dynamic way of identifying the actual problem and fixing the problem. And some tiny babies, we will scan them empirically. When they're 12 hours old, they get an echocardiogram. If you go across the country, most people don't want to touch these babies because they're afraid they'll make them unstable. Our people kind of can perform these ultrasounds in like 9-10 minutes and get all this information because they're neonatologists. They're used to handling tiny babies, whereas an echo technician from another division, they're a little scared of these small babies, and it can sometimes take longer to do these assessments.
And with that assessment, what do you determine from that? How does that help you, or what? Does that diagnose other things that's wrong with the baby? I mean, where do you go with that?
Yeah, so basically we may find that one, the heart's not contracting, so let's give a medication to help it contract better. Two, we may find that the blood flow is going to the wrong place. There's a blood vessel called the PDA, which patent ductus arteriosus, which should close in a normal term baby, but in a premature baby, it stays open. And what it does is it diverts blood into the lung, but not to the other organs. So the brain, the kidneys, the bowel may get less blood supply. And again, this is hard to diagnose from the outside. So we perform these assessments to identify this problem early on, and then we provide a medication to try and close this particular vessel. So, these are just two examples of scenarios. Sometimes the pressure, everyone is familiar with high blood pressure.
Right.
You can have high blood pressure in your lung, meaning the blood doesn't get into the lung to get oxygen. So sometimes that's hard to diagnose. So we will give a medication to relax the pressure in the lung. So the key to this is identifying a problem when it's not immediately obvious, and don't wait for the most immature, vulnerable baby to become unstable. Can we prevent these things? And that's kind of really the holy grail of the field of hemodynamics. And what was particularly impressive was when you go to a program that already has exceptional outcomes and exceptional focus on these tiny, tiny babies, both at the level of the obstetricians, the nurses, the doctors who already were providing exceptional care for these tiny babies. And then we add this on top, you go from kind of, the top of the Premier League to the top of the world.
Yeah. Do all babies have on a premature heart? I mean, obviously they're premature. Or they have deficiencies in their hearts?
To a certain extent, yeah, they all have something, but there's differences in tolerance. And it depends on the circumstance. Sometimes before the babies are born, they may be stressed. There may be inflammation. The blood supply through the placenta may not be as good. So those babies come out and may not be as strong. And those are even more babies in need to a certain extent.
It's amazing. So 88 beds, right?
Yeah.
And you're going to 100, would you say 109? And
the hope is, sometime in the next 3 years, we will expand. And obviously, our mission is to provide the best care, not just here in Iowa City, but for babies all across the state and the region. We have mothers who, in their home state, are told your baby's too small. There's nothing we can do. So they get in the car, they drive to Iowa City. They may hear on social media about our program. So they drive here, they book into a hotel, and they show up at our obstetrician's door to say, hey, I'm at 21 weeks or 20 weeks, and we will provide care for them.
Wow, that's fantastic.
Yeah. So the reputation has extended,
So it's not just Iowa.
Not just
Not
that,
referrals
it's not just the medical people. It's amongst the community of parents.
Are you usually full?
Yeah, we're
With the
usually
beds?
full, which is why we need to expand to 109 beds. Yeah, we're busy and we're full.
So tell us about your staff. I mean, I'm fascinated by people that can work with, premature babies, because I'm sure they're just so tiny. And talk about your staff, and then how did you handle COVID with your staff and the babies? How did that work for you?
Yeah. So I think the main thing is that the success of our program is kind of the symbiosis between all members of the team. Okay, the nurses, the respiratory therapists, the dietitians, the pharmacists, the social workers, the parent liaisons. I'm terrified of forgetting somebody, but it's a full team of people. And when we round every day, everybody is there looking at every element of the program to come up with a plan. One of the unique aspects of our NICU, and this is something that existed kind of prior to me getting there, is kind of in most NICUs, you may have, let's say you have 80 babies and you have 4 teams and you divide it up 20 each. So on that team, you'll have some sick babies, some moderately sick babies, and some convalescing babies. We don't have that concept. We have what we call a neonatal critical care unit, which is a 12-bedded area in which the sickest patients, not just the most premature babies, but babies with other problems, heart problems, kidney problems, et cetera, are in that area. And it's one-to-one nursing. So each patient has one nurse. The doctors, the intensive care doctors, don't have a big team, so they have the time to actually spend on the details of these tiny, tiny babies. So this critical care concept is also unique to Iowa. And once the babies are getting more stable, then they move to one of the convalescing teams as they go through the system. So that I think it's a key part. But I think what sets Iowa apart, again, I've worked at many NICUs in many countries, is the culture and the belief. In many places, people believe these babies are too small. There's nothing we can do. And they may try to resuscitate, but the mindset's not there. It's like when you take a sports team I'm going to choose the FA Cup in England, and you're going to play Liverpool, and you're in the 4th division, and you already believe you've lost.
Yeah.
Okay. Some teams in the 4th division can win.
Right.
It's all about a mindset and a belief. So everybody's on board. Everyone believes that they can do the best. And it's not that every single baby survives, but if you look at 22 weeks gestation, for example, we have a survival rate of just over 60%. The rest of the country is less than 10%. Go to 21 weeks. Again, it's too early to have numbers of survival, but there's no program in the country that's had 4 survivors in the last 18 months at 21 weeks gestation.
That's amazing.
So it would be remiss of me to not remind everyone that this is about the obstetricians and the care they provide to the mothers. And it's not just about the doctors and the NICU, it's the whole team and everybody working well together, and then we bring in these specialty teams like hemodynamics, better care of the heart. We have a specialty lung team with doctors that are focused on the lung. We have a brain team, a neurocritical care team with people that are specialized in the brain, and all that expertise together really, it's like any team, the more you invest, but the team has to have a culture, it has to have tactics, which is what I think we've done well.
So you have 12 patients in the critical care, right? And you said one-on-one care, even all night long?
All night long.
A nurse and a doctor and a physician there?
Not one doctor. So there's one physician for that area, but one nurse that's there at the bedside constantly with that baby. Yeah.
That's amazing.
Obviously not the same nurse for 24 hours,
Right.
but yeah, that concept is one-to-one. And that is hard to find in NICUs. Most of the time, it's 2 to 1 or 3 to 1.
Wow, that's amazing. That's a lot of staff, that isn't it? So,
It is.
So how did you survive COVID with your staff? And we're going to talk about that a little bit because that was hard on everybody.
It was hard on everyone, yeah. And obviously, you know, the good news in this is that COVID was really not a disease that had major problems for babies.
For babies. Okay.
You know, we had maybe 2 or 3 babies with COVID, and they were not that sick. You know, obviously, the conditions, you know, were exactly the same for us. The masking, you know, the pressure of the system, you know, and we were a full NICU, you know. And I think a lot of people forget that, you know, our ICUs were busy, but the NICU was also busy throughout, and we had to go through the exact same conditions from a COVID perspective, you know. And again, the uncertainty of not necessarily knowing at the beginning, would there be an illness that could be quite severe? So we actually had an area in the NICU, which was where we would cohort kind of the high-risk situation. So when there was a mother that had COVID, obviously that baby's at risk. Or if the baby had COVID, they would be in a certain area that we had to staff separately, you know, to make sure that we didn't have transmission across the NICU, which would not be good.
Right. And then you'd have to check your staff too, wouldn't you?
Oh, absolutely.
All the time were they tested? And
yeah.
Yeah. So it
was a big deal.
Yeah, it put a lot of pressure on everybody.
It did.
Patients, the physicians.
Yeah, well, the whole system, you know, the other part that people don't appreciate is, you know, evolving from a team that's very close together, that meets regularly, that we have our academic conferences, we're all in the same room, et cetera, and then suddenly we're on Zoom.
Yeah.
Zoom education sessions is not the same,
right.
You know, and, you know, when you're talking about a controversial area or a controversial situation, and somebody asks a question, and maybe they're asking it with good faith, but it doesn't come out the same. You don't see their face so much. It can, you know, it's much more difficult to navigate education in the Zoom world. Like it's great. You can stay at home, you can do whatever, but from a team bonding and a team collegiality, it's not the best thing.
How many babies are born at University of Iowa? Do you know a year annually? So
that number is rising. You know, when I got here, we were somewhere around 2,500. We're now kind of in the mid 3,000, 3,500, wow. You know, approximately. And that figure is projected to go up as more hospitals are closed, the small college hospitals.
Right.
Mothers have to deliver somewhere. And, right. You know, again, that's also part of the reason we need to expand. Not just that we're full, but there are more projected deliveries for the area.
So tell us about do you have to ventilate the preemies?
Yes.
I'm amazed the equipment. Who designs the equipment? I mean, do you guys work on innovation with designs and surgeries and just the equipment and tools and how you perform the surgeries?
Well, yeah. So we don't do surgery. We do certain right. procedures. We put tube into the lung, a breathing tube.
Right.
We use the umbilical cord. Okay. Huh. In the umbilical cord, there are 3 vessels. There is a vein and there are 2 arteries. And we use those. We use the vein to provide nutrition. So we put a tube or a catheter, like a cannula, a long cannula, into the umbilical vein. And that gets fed up to close to the heart. And we can give nutrition through that for the first 2 or 3 weeks till the skin is more mature. And we use the artery. We put another catheter into the artery that we use for taking blood samples. So we can monitor the baby's body chemistry, his hemoglobin, et cetera, But we can also monitor blood pressure through that catheter. And these are very, very small. Now, as we go to smaller and smaller babies, it's getting to the point that the babies are almost too small for these tubes. And that's going to be the line in the sand. You know, if we want to go below 250 grams, is there a tube that's small enough? You know, and obviously that requires kind of, you know, liaison with industry and so forward, you know, to deal with that. Our former medical director, John Klein, is a world expert in what they call the jet ventilation or jet ventilator. And he, again, like myself, he goes around the world teaching people how to use this very specialized type of ventilator. And the story of high frequency is a very, very interesting story because, when we breathe, we take a deep breath in and out. These type of high frequency ventilators, it's like the baby is oscillating, okay? And where that came from is if you look at dogs, look at how they breathe.
Mm-hmm.
It's this it's like a vibration type of breathing. So actually kind of one of the pioneers of what we call high frequency ventilation was a guy by the name of Charlie Bryant, who was actually in Toronto at SickKids and did some of the seminal work on this special type of ventilator where you keep the lung open and you vibrate it to clear carbon dioxide, So, our group is constantly at the leading edge of not just doing stuff, but studying. Studying, if we do this, what's the impact? Is it enhancing care? Are there any side effects? And there's a whole team of people with different areas of focus. We have a researcher, Jenny Burmick, that I hired or recruited from Michigan, who has got this very unique focus in the immune system, which nobody is thinking about, and how does the immune system impact some of these diseases we manage, in the NICU? Because, when I say to parents and talk to them, I say, neonatology, it's a two-edged sword. Everything you do, we do to keep the baby alive. But the baby's immature. The organs are immature and they're vulnerable. So the drugs, the therapies, there's going to be some side effect. And our job is to get, the biggest bang for our buck, the biggest gain with the least, side effects. So we're constantly looking at every aspect to see, okay, let's not rest on our laurels. Again, back to professional sports. We are the leading program for these two domains, tiny babies and hemodynamics. But if we don't keep improving and keep asking the question, can we do better? Somebody else will come along and go past us, and that mindset is very prevalent within the program.
Do you study DNA at all in your group with the parents and what could go on with the baby and how does that work?
Yeah, so we have something called a biorepository. Another new recruit who actually is a kind of a psychology PhD person who is doing some research on the physiologic stresses. Her name is Alison Momani, and she is the lead for our biobank. And what the biobank is, we consent parents to get samples from the babies and sometimes from the parents that we can secure. These are, genetic samples that can then be kept for future research. So if somebody wants to know this particular disease, is there some genetic determinant as to why a certain thing happens? That material is kept there, and that's not just for our own researchers. We have researchers from different other NICUs that reach out to us for samples, and at the end of the day, genetics explains so many things. And if we don't think of the genetic determinants, we're gonna miss stuff.
So when you have a baby in a NICU, a lot of things could happen. I think a lot of things, it's daily progress with the parents. If this could happen, the baby may have this, maybe have that. It's hard on parents because they don't know, right?
Oh, it's.
Maybe has other issues down the road that they survive it, but they could have some brain injury or damage mentally, and that's how do you determine all that? It just analyze it daily.
I think the first thing, at least my own personal perspective, we need to educate parents
right
at the beginning because this is the unknown for them. You're expecting to have a full-term baby, and suddenly your baby's born, let's say 22 weeks, and it's 300 grams. What does this mean?
Right.
And the general consensus is these babies are too small to survive, and if they do survive, they'll have major problems. Right. The first is the recognition that that's not true. Many small babies survive, and many actually have very good neurological outcomes, but some don't. And obviously, reminding parents that this is a very, very long journey, and even the babies who do very well in the first few weeks, that's almost the worst situation because you get lured into this false sense of security. There can be problems that can just suddenly appear. I've seen, babies who've done completely, everything's gone perfectly. And maybe at 3 months, they get infection and die. And that's devastating because you think you've got over the worst.
Right.
You see the baby's gotten bigger, maybe they're twice or 3 times their size, and this happens. And then, of course, the neurological stuff is another, uncharted territory to a certain extent. We have certain tools like ultrasound that help us pick up big things. If there's a big bleed in the brain, if there's major damage, we can see that. But it's not good enough, which is why one of our hopes is when we expand to the new NICU, we're actively talking about putting an MRI in the NICU.
Oh, really?
Yeah. So, and that's a game changer because you can't take someone who is 400 grams and put them in an incubator and move them off to the bottom of the dungeons in the hospital
Right.
to this remote place to do an MRI. So the secret to doing not just clinical scans in these tiny babies, but also research, studying the heart and the lungs to a higher degree, is to put an MRI in the NICU, and then the baby doesn't have to leave the NICU. You can get it all done there. Obviously, putting an MRI is not a cheap endeavor.
I was going to say, that's expensive.
It's an expensive piece of equipment and stuff like that, but we have a very committed hospital, and kind of our leaders are good people that want our program to continue to be the best. So we're currently looking at ways to see, can we make that happen.
Yeah, and they're kind of heavy too. So structurally, you want
They
to
are
make sure
pretty
you
heavy. Yeah.
Yeah, it's neat. So I had I don't think people realize all what you do over there, and it's so neat that you're here at the University of Iowa. I had a cousin that had a baby that was born here premature, and then he had, I think it was adult-sized kidneys that was born as a baby, and I don't know how often you have that or not, but I know they were here for about a year, I think, and the baby's doing fine now, and they had numerous surgeries, and it was quite, they have an Angels website, I think, where they can kind of log in and talk about all the great care and all the things that went on with the baby. But I think another thing that they were truly blessed of your care that your team gave to the baby. One of the things that I think people miss is, where do you stay? Where do you go? And, we know a few of the folks at the Ronald McDonald House right near the hospital. There's 2 of them. There's one for, I think, older folks, and then for families with babies. And what a nice place that is. And they don't even ask you your income level. You can just go in there and stay. I think that's really neat. And then, do you know where else people go? They just get a hotel room or stay with friends, or
Yeah.
I mean, because it's pretty traumatic. Because if your child's sick, you're going to be here.
Oh yeah, and again, the most premature babies sometimes can be here for 1 to 2 years, and as I said, it's sometimes some babies we can move them back to hospitals closer to home, but those babies have to have a certain level of stability, and if we can do that, we will certainly do that. But there are other patients, like if you have adult-sized kidneys, and it's just because they're bigger doesn't mean they're better. Typically, this is something called polycystic kidney disease, and the kidneys are bigger, but they just don't function. And obviously that's another element of concern, where you now have, the journey of being kept stable, but also the journey of waiting for kidneys, healthy kidneys.
Right.
And obviously we have the Ronald McDonald House, but we have 87 beds.
Right.
We will have 109 beds. We don't have 109 rooms in the Ronald McDonald House, to do that. So people do have to find somewhere. And for some people, that can be really, really difficult, and that comes out of their own pocket. They don't have to pay, for that. And, that's the hard part. But the parents want the best for their children, and they will make that sacrifice, to do that. Now, some people, where it gets more complicated is, you have a premature baby or a sick baby with some problem, but you have other children.
Right.
And you can't abandon them
Right.
to be here all the time. So some parents get into this habit. One parent will come and spend a week. The other one will be back with the other children, and they do the relay race of coming and going. And it's a huge impact on life, and people don't realize that. It can be really hard. And then when things go wrong, who's your emotional support?
Right.
If you're here on your own and all your other family members are in a different state, or
So you have social counselors too to
We
talk
do.
to the parents and
yeah, so
help them?
we have social workers. The other thing that I kind of was very keen to see introduced, and I advocated for 2 years to have what we call a parent liaison role. We now have one, which is a parent who's on staff. They're a paid employee, and their job is to be there for parents. So they don't think like us as the team; they
Right.
think like parents, to help them understand, to make sure that they are aware of, resources, or just to talk.
Yeah.
I think that's we have one at the moment. I think we need a lot more than one, but it's a start.
That's a great idea, by the way. Help them guide through all the
Absolutely.
things that are going
Well,
on.
think about it. And some people can be a little distrusting.
Yeah.
Maybe they're not telling us the truth or whatever. Having a parent who you feel is on your side,
Right.
that's a huge game changer.
Where did the wave come from? Where at the football game
Oh,
they're
I'm probably-
waving at the kids after the first quarter.
It's a great question. I'm probably the worst person to ask that as a non-Iowan, but
Yeah.
obviously, it's now a major international
Yeah.
kind of thing that has identity.
Yeah.
I've been there. We've done the wave. I've been on the other side, up in the 12th floor. It's a hugely important kind of part of our identity now. And obviously from a fundraising perspective, the wave shirts and T-shirts,
Yeah.
et cetera, et cetera. But honestly, I'm not sure who was the first person and how it happened.
I can't remember now either. Actually, when you think about it, I think it's neat because in between the first and second, at the end of the first quarter, both teams, they come out on the field and they wave. The coaches, all the kids, and the opponents do it too.
Yeah, everyone
And then you can
understand.
see people waving back. I think pretty much everybody in the crowd has a tear in their eye
Absolutely. No,
because they're thinking of those kids and what they're going through and the families, and you probably all know somebody that's been through there, and it's pretty traumatic. So
like I think I think the proximity of the Children's Hospital overlooking
yeah, the stadium.
the football stadium, I don't know that exists anywhere else.
Yeah,
I think it just was almost the perfect coming together of sport and
Right.
healthcare. And I think there are many, many other examples in life of sport and healthcare. I learned to be a leader. All my leadership skills were coaching soccer.
yeah.
All of them. I did it for 10 years in Canada. Our team, U17, U18, was number 2 in the country.
Oh, really?
Oh, yeah. We had a big thing. I took my team to play soccer in Brazil, Uruguay, against some professional teams. So I learned the importance of, 1, culture, 2, tactics, and
Yeah.
3, that you can't treat everyone the same. You got to handle them all differently on the
Right.
soccer field. And I think that interface between sport and healthcare is really important.
Yeah, it sounds like you've done that at Iowa. Just taking what you learned from the soccer coach, huh?
Oh, absolutely.
That's
No.
great stuff. That's great stuff. What are some other innovations you'd like to talk about? Is there anything else that's going on up there, the NICU,
Oh,
that you're working on?
yeah. So we talked about the hemodynamics program. We talked about the tiny piece. We talked about the immune system. I think the other part that was a huge culture shift was the introduction of our neurocritical care program, which is not just people that are interested in the brain, but monitoring. And one of the things that we need to recognize as physicians is that, and physicians can have egos and we can think we always know the right answer, but our eyes are only as good as what our eyes see. And there's a lot of information coming out second by second on these babies. So we have a artificial intelligence system called SickBay, which basically the easiest way to describe it is like a giant brain. All the information from every monitor, the ventilators, goes into this giant brain. And we have researchers. So Danielle Rios is our lead for SickBay. And she is studying, can we use this complex data to better understand risk and better understand when something is going wrong? Because, we don't want to wait to have the echocardiogram. We don't want to wait to do the chest x-ray. Can we identify earlier that something it won't tell you exactly what's wrong, but it'll tell you something has changed. And I think the next phase of medicine really needs to embrace artificial intelligence and actually how that will kind of help our doctors and nurses and other healthcare professionals better know when something is wrong. Similarly for the brain, from a neurocritical care perspective, we're actively doing, research, looking at, the interface between the heart and the brain, the lung and the brain. Can we better identify, scenarios that can compromise the brain so we can prevent brain injury? So that's kind of, our focus is very much on prevention, not try to fix a problem that's happened. Let's try to prevent a problem happening.
That's amazing. Yeah, AI is the talk of the town now, and I can't imagine what that'll be like 10 years from now.
Oh, I know.
With AI.
Yeah, absolutely.
in a positive way.
Yeah.
Amazing things that it's doing. So,
Yeah.
my oldest granddaughter had a brief stint in the NICU when she was born premature. I think she was 5 pounds, 5.5 pounds, and the care was just fabulous, just amazing. So, I think people that I was with my wife when we had our babies. I was right in the operating room, and if you've never witnessed childbirth, it's truly a miracle. And it's amazing, and what you guys do is amazing, just to keep them alive, and especially 21 weeks, 22 weeks. Yeah. I still can't get over that.
It's mind-boggling. I remember when I started off doing neonatology in 1995. 24 weeks was a big deal.
Yeah.
And with every 10 years, it seems to be the line goes down by 1 week gestation.
Great.
Yeah.
Anything else on innovation before we wrap up today? Anything you'd like to comment on your department?
No, I think there's so many people that are doing so many, amazing work. One of the other areas is it's less on innovation, but more on system, but is our transport service, reshaping our neonatal pediatric transport team to make sure that we can, not every extremely premature baby is born in our hospital. Sometimes they're born in community hospitals. Mm-hmm. And you can imagine these people never see these tiny babies. Yeah. Once every 5 years, and someone is 300 grams. That's terrifying.
Yeah.
So one of our strategies was to let people know that if you call us, we will send our transport team there to attend the delivery, to help those doctors and nurses. Because again, it's about the skills. If you're not able to put in the breathing tube,
right,
the baby will die. So kind of, we're constantly looking at ways that we can enhance our transport system. We can bring out now one of these high frequency ventilators on transport. Once upon a time we couldn't do that. So there's a whole ranges of advances, in transport medicine that really allow us to take the intensive care to the baby. And then safely bring that baby back, to our program. So
is that in an ambulance or is
it's ambulance or helicopter?
In a helicopter.
It's
too.
It depends on so many things. The weather,
right?
It depends on the distance, and obviously we can take either air or ground transport.
Wow. I suppose you got a certain amount of time to get them up
here,
right?
Oh, yeah, absolutely. And, you're talking about the most vulnerable, highest risk patients. And taking them in the air.
Wow.
It's kind of scary.
Yeah, it is.
But these people are really good. Our transport team are amazing people. They're doing a fantastic work.
That's another neat innovation.
Yeah.
That's great.
But
well, listen, it's been fantastic to have you here. Appreciate what you do for Iowa. We're just blessed to have you, your whole team, all your care people, the hospital. Tell us a little bit about the Children's Miracle Network. Does some of that money come up to you folks in a NICU, or is it mostly cancer research, peds? What?
No, there are, indirectly, some of that money will come to us through research. So there's grant competitions and people can submit, a grant or a study to be able to kind of, further advance our mission. So kind of indirectly, we will have access to that. But there are other opportunities, whereby we have other donors that will provide money. We actually have the Savvy Ferns research grant competition through the Ferns family, who very graciously provided a donation to us in the NICU. And kind of, every year we have a competition. We award 2 grants. It's kind of like seed funding catalyst grants that will help people, particularly junior people, get off on their journey of doing research. So, it's there's so many elements to our program. I think it's an amazing program, but the program is only as good as as the people. And as we get bigger, that creates even more challenges because a bigger NICU is not just more nurses. It's actually the whole team. And one of our greatest challenges at the moment is we have a huge nurse practitioner workforce. They are kind of one of the key elements of our program. We've got 35 nurse practitioners. To have a bigger NICU, we're going to need to find another 10, 15, and there's a national shortage of nurse practitioners. So we're currently looking at ways, how can we expand our NICU, but how can we do it in a way that we can acquire these talented people who are at the core. They are the core of our NICU. They're there every day. The doctors come and go. They're at the front line, and they're doing a licensed practitioner role. And they provide that continuity throughout the year. But we need more of them. That's not easy to find.
Not bad.
Yeah.
A lot of people are short of a lot of employees. Aren't they? It's just
Absolutely. Yeah.
all the way across the board. So, well, we definitely have a jewel of the world, don't we? The NICU, University of Iowa. It's world renowned.
Yeah.
And it's amazing. It's just right down the street here.
Absolutely. So, it's a privilege to be the leader of that program.
Yeah.
An absolute privilege.
I bet. Well, we appreciate all the work you do and the research you do, and people can come in and learn how to do things. It's just fantastic what you do. So we're really blessed to have you.
Thank you.
Thanks again for coming in, Pat.
You're welcome. Thank you very much. Okay.